Welcome everyone to today's webinar. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. George Nassif received his medical education from Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania. He completed his internship at University of Pittsburgh Medical Center. He completed his general surgery residence at Allegheny General Hospital in Pittsburgh, Pennsylvania in June of 2011. During residency, he received several awards in both research and teaching. After residency, he completed a fellowship in minimally invasive rectal cancer surgery at the Lanakanau Medical Center in Wynwood, Pennsylvania, focusing on distal rectal cancer surgery and sphincter preservation surgery. He then went on to do a colorectal fellowship at Florida Hospital in Orlando. He is board certified in both general and colorectal surgery. He has a specific interest in TAMIS and TATME, being intimately involved in the evolution and maturation of both techniques. He is active in both clinical and outcomes-based research. He is involved with the COC Measures Committee, helping create and implement surgical metrics to help develop rectal cancer centers of excellence. He is faculty and mentor to several colorectal international and research fellows each year. He is also the medical director of the ERAS program for Florida Hospital. When Dr. Nassif isn't working, he enjoys spending time with his wife, Allison, an anesthesiologist, and his 4 sons, ages 2, 4, 6, and 8. Dr. Nassif, I'll now turn the floor over to you.
Brian, thank you very much. It's my pleasure to speak today, but I do want to give a couple disclaimers before so. This talk today, I hope you understand and enjoy it, because this is more of a passion to me. This is something that, with the help of some folks in my office, we've sort of taken this concept of enhanced recovery and molded it with the opiate-free pain management. And so it's really something I love to talk about. I love to answer questions about anything that you may have. Please write them down. We can talk at the end. If we run out of time, there's always ways to get them to us through emails. But that's what I want to understand, is that I'm here after you hear this, and if you have any questions, I'm available. So we're going to start moving on with the presentation. So these are the disclosures that I am paid agent on behalf of Mallinckrodt. As you can see, there's sign-in sheets and the objectives. So the objectives is, first, we're going to discuss the prevalence of the postoperative pain and current strategies for pain management. We're going to look at the potential benefits of opiate-free protocols, including in the ERAS programs, and we're going to learn from the early adopters of the opiate-free ERAS, if you want to say, more tips and tricks on how to progress your program. So, you know, when we look here, I may not agree with this completely. Opiate-free analgesia may be a goal, but opiates still have its place, and I believe that somewhat. It's also important to know that I'd love to have everybody be able to have great pain control and not have any opiates, and I think that would be wonderful. However, that might not be 100% realistic. So even if you're looking at this talk, and I think that if we take into this not only improving the patient outcomes, improving pain management, but also from a social standpoint, that even by reducing the way we write for opiates and the way that we have patients use opiates, I think that is something that can't be overstated. So we look at pain management, the important component. This really starts in pre-admission, pre-operative, intraoperative, post-operative, discharge. So all the way through that continuum of when we encounter the patients for the first time in the office till they follow up as an outpatient. That entire continuum has a lot of different areas where we need to interact with the patients and where we can then have the patients sort of understand what we want to do, understand our goals of not only helping them, but to help them in a better way than we have in the past. So when I say a better way, when we look at this pain graph here, this is a study done by T.J. Gann, and this was looking over 30 years and questioning patients about how they thought their pain was handled, whether they had any pain, from extreme pain to slight pain. And we see that there's not much progress we've made over the last 30 years. And if we look back in that last 30 years, we see that people have done robotic surgery, they've done single site surgeries, they've done all kind of different innovative surgical techniques, and we've innovated so well there, but yet with pain, we have not made any improvement. We've just let it be, and we've assumed that you just give narcotics, and that's it. And truly, I think that we are starting to understand on many different levels, clinically as well as socially, that this is a problem and that we can do better and we must do better. So when you look at how to address this, we looked at the beginning. In the past, it used to be opiates. That's all you had. So you gave opiates, you gave more opiates, and you had the traditional surgical approaches. And even today, trying to change to the future, you still look back at the past, and it's what we see in the hospitals. We all say, with our air quotes, culture. This is the culture. The culture was we gave narcotics, we did open surgeries, and that's what it is. Presently, right now, what we do is we are going through the MMA and multimodal analgesia, and we're moving this with enhanced recovery programs. And what we're seeing is that by doing this, we're actually improving the patient's care. This is then catapulting us into the future, which the goals are to, again, continue the multimodal analgesia, this time being more opiate-free, and using that in conjunction with the enhanced recovery programs to make the entire experience and the outcomes much better. So using the opiates in the perioperative setting. So this is and I'm going to keep saying culture because this is what we've all been taught, and this is what we all think is how we have to handle pain medication. So we give somebody some opiates. If they have any pain, then we increase it and just give more opiates. And if they have still pain, we again just increasing it, giving more opiates. So this has been our way to think of how we help patients. We think post-operatively help them by giving a little bit of narcotics and opiates and going all the way up until they don't have any pain or discomfort. And, quite honest, that's not a good way to think because that has a lot of consequences with it. When we look at this study here, this is a paper done, again, by T.J. Gann, and what he looked at here was basically with these patients asking theoretical questions about not only pain management, but side effects. And when we see on the study is what it showed was patients were much more willing to have a little bit of pain or some pain and not have the side effects that come along with narcotics, including nausea, vomiting, itching, constipation. So we really, when we look at that, patients did not want to have those complications. They would rather deal with a little bit of pain, okay? There's another paper here, and I want to emphasize that this is looking at anesthesia. So you'll hear me throughout talk between anesthesia and analgesia. And I look at that as anesthesia as their part, analgesia is my part before and after. I know this even happens in my house because my wife's an anesthesiologist. So we get into this argument about anesthesia or analgesia, which more important. But this study here looked at patients, and they were randomized during surgery, during the anesthesia, between a group that received fentanyl, that received esmolol, and that received remifentanil. And then they looked in the PACU how much narcotics or fentanyl they received there. So the patients that received esmolol received much less narcotics than the ones that received remifentanil. And this is, again, looking at the hyperalgia, which for a dumb surgeon like myself, we look at and ask our anesthesia what that is, and they will tell us that by giving the narcotics, you then need more narcotics to improve over the pain. So you become more sensitive to pain the more narcotics you get. And that's the way I look at it. So if we don't give them narcotics during the case, then they'll need less in the recovery room. So here is looking at 3 studies, and this is looking at opiate-naive patients. And as you can see, this goes from If you want to see 12, it's an age study, if you think of it that way. The first one's looking at teenagers to early 20s. Second one's looking at 18 to 64, and the third one's looking greater than 66. And really what it's telling us is if you looked at patients who never had any kind of opioid, but then had some surgery or something in the hospital, if they received a narcotic script, then there were, in the percentages there, 5%, between 5 and 7% of those patients then went on to have multiple narcotic scripts, or we'd call them new persistent opiate users, meaning that they then started to take narcotics after 90 days from their injury. So, this is starting to bring us into, socially, what are we doing here? We have somebody who may come in with an appendectomy or a gallbladder, and we're giving them narcotic scripts, and 3 months later, they're still taking narcotics, okay? So this is really an issue that we have to address, and so we can't just get them out of the hospital that day and say they're gone, they're not my responsibility. This is our responsibility as clinicians to monitor this. So we're going to look at the present now and looking at MMA, or multimodal pain management and enhanced recovery. So again, this is looking at an outcomes. This is looking at hip arthroplasties. There's about 500,000 patients in here, and they put the patients in groups of patients who received opiates only, who received an opioid plus one non-opiate, patient that received opiates plus two, and then a patient who received more than 2 non-opiates plus an opiate. And when they looked, and they found that when using the multimodal management, that they decreased the side effects of the narcotics. There was 19% fewer GI complications, fewer respiratory complications. The length of stay was decreased by 12%, as well as the number of scripts that were written were 19% less than the ones that receive opiates alone. So you look and see, can we improve on postoperative pain and reduce? Sure. So, when we add these multimodals and we add the enhanced recovery programs, are you changing the surgery, and are you changing the actual patient? No. But what we're doing by enacting these protocols is that we are causing things to be more streamlined. We are thinking before we were actually doing, because there's a set up protocol. So that means that in the operating room, hemodynamics is managed better, fluid administration. We're feeding patients earlier. We're giving many different things to treat their pain rather than just narcotics. So by implementing these programs with the multimodal analgesia as well as the enhanced recovery, we're improving the quality of the product of care we're giving from preoperatively all the way till the patient leaves and goes home. So this is a great opportunity, again, that when we can start to reduce the opioid exposure, because we're doing many things to improve the outcomes. So here we looked at length of stay. And so, and you look at this study here, this was to looking at whether you use the ERAS program in colorectal surgery would increase the cost or length of stay. And so what they did is they looked at patients, if you want to think of it, it's probably best described as a case match study, meaning that they had 1 year's worth of patients, which was 146, that had ERAS implementation, and then they took the 160 patients that were the prior year before they implemented the ERAS program. And what they found was that there was a 17% reduction in pharmacy costs. There was a 15% reduction in total indirect costs in the hospital. There was a faster recovery, so 40% of the patients decreased the median length of stay, and that 71% fewer morphine equivalents were used throughout the hospitalization. So, just implementing this program on a direct 1 year to the next year, they had significant decrease in cost as well as increased recovery and decreased use of opiates. So what does the future hold? So we look and we say, if we build this picture, and this is what I always tell the fellows when we teach them, we build a picture in our head and we looked at where we were and what we're building. So right now in our minds, we have an enhanced recovery program. We're using opiate-sparing multimodal pathways. And now what is the future? What can we do to make this even better? And I think that we can improve by decreasing the opiates, and that'll be immediate postoperative period. That's going to get patients out quicker, and that's going to decrease the ERAS. Immediate postoperative period, we'll have the postoperative hyperalgia. So that's what I talked about earlier. when I said that by not using the narcotics in the operating room and not using them after, then their pain will be better controlled with the non-opiates because they have not decreased their pain sensations. And then the long-term goal is really, this is where we become the social issues, where we want to send people out with less narcotic scripts, putting less narcotics on the streets, and to have patients less exposure to the opiates. So all of these things playing, I think that we could make a big difference. So while the ultimate goal is to achieve opiate-free, opiates still have a place in pain management, and I agree with that. And by no means do I want to say that no patient that ever comes in the hospital is ever going to get a narcotic. You're still going to have patients that get narcotics. You're still going to have patients that get the same amount of narcotics as they did before. But I think, again, we want to decrease the amount that we use and get those select patients that don't need to have any at all. So who's involved here? The stakeholders of the common goal, right? So this is where it is very important to understand that whenever you're doing, whether it's an enhanced recovery program, whether it's doing opiate-free multimodal, it can't just be driven by one person. This is an entire stakeholder project. This is the surgeon, the anesthesiologist. This is the nurses on the floor in the pre-op. This is administration. This is everybody on board to make this entire process successful. And so, you know, number one, we look at opiate-free anesthesia in the preoperative setting, and we'll go over some specifics. But again, you educate the patient. You have to talk to them a lot preoperatively and let them know what's going on. Just as when they come to the pre-op holding area, the nurses know what goes on, and they get a non-opiate medication. So that's the first spot where we make improvements. The second is during anesthesia. So when you have your anesthesiologist on board, there's many different protocols. It's almost like dealer's choice, but there's a lot of different things that they can use to limit or make this opiate-free anesthesia. And then afterwards, we as the surgeons have to be really in tune with the patients as well as the floors and the nurses to really get everybody on board about the opiate reduction. So again, when everybody is together and we're all on the same page, it can lead to success. So, you know, implementing here, when we look, this is patients undergoing colorectal surgery and focusing on the opiate-free and MMA components of the protocol, okay? I am going to briefly go through this because when I go over my specific protocols, I like to spend a lot more time on it. So when we look here, we said that the problem is that if the anesthesiologist is on board, so if you have the first two out of those three components that we just talked about, the preoperative and the anesthesia are on board, and they give them no narcotics. But yet you don't have buy-in from the surgeon or the surgery department or the nursing floor for surgery. What happens is that they may not get narcotics throughout those first two phases, but when they reach the floor and you're giving them narcotics, then we send them home with the same amount of narcotic scripts. So if we don't do all three phases, then it doesn't really improve. So we can have opiate-free anesthesia. If we don't have opiate-free analgesia, it's not going to make a difference in the end about prescriptions at discharge. So let's look a little bit more about what is through the opiate-free analgesia. Now, again, I'm going to go through these a little bit quickly just to show so I can go and spend more time on my slides. But what we do is we think of opiate-free analgesia as, hey, let's hit pain in this patient from everywhere we can possibly hit it to make an improvement without, again, going to an opiate. So we can do that peripherally. And with that, you can do local blocks. You can use anti-inflammatories, NSAIDs, COX-2s. We can do all these things. You can hit them from the afferent pathways. This is a regional block. Some places have better access to regional blocks, some don't. But again, you can hit them from a regional standpoint. And we can hit the pain receptors centrally through epidurals, intrathecals. We can use different medications like the IV acetaminophen. You can use the Neurontin gabapentinoids. You can use magnesium. You can use adrenergic. So really, there's no one protocol that will work for everybody for a couple reasons. Some people aren't familiar with the medications. Some people don't have access to the medications. But what you can do is you can build a specific program that will work for you at your hospital with the main goal of let's hit this pain from every different one of these avenues and avoid just giving the narcotics. So when implementing an enhanced recovery program. So ERAS provides an opportunity to implement opiate-free strategies, easy to follow. Well, it's sort of easy to follow, but we'll go over. So the three key components are this, is that the patients must, it's important that the expectations are set forth. Now, we do a really good job at our place by educating them from the time they're in the office until they have the surgery and even when they're discharged. And I think just having this increased communication and increased presence of the surgical team with the patient, I think it makes a big difference. I think that they really do and are able to improve them, their care, because we're communicating with them. We understand them, they understand us now. So again, we talked that opiate-free anesthesia alone will not reduce the opioid exposure. So again, this has to be buy-in from everybody involved. You can't just have one person that wants to do it and others who do not. Lastly, is it possible? I think it's absolutely possible, and I think that I always go back to saying that I hope that when TJ Gann does his next study, that's at the 4th decade, that we have made significant improvement on that, and I hope that I'm a little bit a part of that, but I hope that we really can make a difference on this way. So in summary of the talk, you know, we look and we say the pervasive usage of opioids in perioperative setting has contributed to an epidemic. I truly believe that. And, you know, we have studies that prove it, but you just need to turn on the TV nowadays, and we know that it's a real problem out there. And, you know, this is something that affects every one of us knows somebody who is affected by this. So it is definitely an epidemic, and I think that we have some obligation of healthcare workers not only to help solve that or not play into it, but also help the patients when they need it. So even with the surgical medical advancements, the pain has still not improved. Again, I hope I'm not speaking too quickly, but I hope that we are able now with these different multimodal analgesias and opioid-free, I hope we finally make a dent in that, and it'd be wonderful to see that chart change. Better understanding of what the opiate exposure does to the patient, and how maybe we're not just helping them by giving them the opiates, maybe we're actually making things worse because of the side effects and the hyperalgia. Clinicians successfully applying opiate sparing, we'll go over this a little bit more, but yes, they're not only applying these protocols, but they're thriving in these protocols. So lastly is implementing the opiate-free can be achieved. It does require buy-in, and I think I stress that with all stakeholders involved. I think that if you have a champion in surgery and anesthesia and administrative and nursing, I think that if you do that and everybody wants this to work, it can definitely work. And I think it's just a matter of getting everybody in the same room together, everybody making compromises, everybody working together, knowing what the final goal is, and that's improved outcomes and experience for the patient. So I'm just going to go over and spend a little bit of time telling you exactly what we do in our protocols. And again, I do want to emphasize any questions you have about this or how we did it. I can answer those, and you can also get these to us via email, whatever. As a side note, our protocol was not easy. It did not happen overnight. We had some really awesome people at the hospital, and we worked together, and we struggled through things, and we made a good process. And once we did the process, we looked at then our audits and really made things better. My nurse practitioner, Kim, has been amazing and has sort of spearheaded everything with me and has really helped us get things moving in the right direction. So the first thing is when we look at our protocols, we have a brief introduction. And what do I say? When I add a patient on for a surgery, I just plant the seed in their head and I say, as simple as, hey, we're going to operate on you. It's going to be different than you remember. We're going to try not to use any narcotic medications. We're going to try to use a lot of different things that are going to get you up and moving around. And really, I want to keep you as normal as you are today, as you are the day of surgery. I want you to eat, walk, and move. That is all I tell the patients. So a lot of times I know surgeons say, I don't have the time. Well, you know, you have the time to spend 30 seconds just to introduce that. So once they hear that from me, Then when they're exiting the office, they get brochures. And in the brochure is a very simple brochure that just goes over what an enhanced recovery program is, and what's its pain management, what do we expect them moving and eating. So it's a little brochure, not too hard. It is educationally appropriate, I should say, because I was a go-getter and made this nice big brochure with literature and data and everything else on it, and I was told that there is no way that is going to be good for our patient population. So I reworked it, and again, made it a nice, easy reading, lots of pictures, quick snippets, and they can go home and read it. The next thing that goes on is we then sort of, if I want to say, it's like a snowball. So once I add them to the case, our surgery schedulers then put them on the ERAS program, and that goes directly to the hospital scheduling, and it will just flag that patient. That patient will then be flagged to go and have pre-admission testing, as well as what we call as our ERAS class, or our ERP class. And it's a 30-minute class given by our nurses and our nurse practitioners in the office. And it's that class, they just go and explain, again, everything that we talked about. Early feedings, you're going to be walking around, we're going to give you a lot of different things for your pain, other than narcotics. And it also gives the patients a chance to ask their questions in a really relaxed environment, sitting in the office conference room, going over all this stuff. So again, we really emphasize they've talked to me, they have their brochures, they've been to pre-admission testing, they've had their pre-admission class. So this now all sets them up for education that, 30 years ago they didn't have. So they've spent a good bit of time to know what to expect of what is coming up for them with their surgery. The last thing is we do have access, and we use a app-based tool. And with the app, the patients have on their education about the Enhanced Recovery Program, and it just gives us a chance to interact with the patient, or they have access to us pre-operative and then post-operatively. So we do have something that allows us to have good access and education for them. So when we're in the preoperative setting, we encourage a carbohydrate-based drink at least 3 days prior to surgery. However, some of these drinks are quite expensive, and the patients do not want to pay for them, and the hospital doesn't want to pay for them. So we've come up with a couple different things. We want them to take apple juice, and there is some of the Gatorade Prime drinks. And what we've done is, with our nutritionist, she looked and she said these carb drinks that you can just go get right at the regular grocery store are similar to the commercially available drinks if they cannot access those. So we do encourage that. But more importantly, what we do with our patients is we want them to be on clear liquids up until 2 hours prior to surgery. So when they get up in the morning, they're allowed to have a drink, they're allowed to have their coffee, and we really encourage the clear liquids, knowing that looking at evidence will tell you that the clear liquids in the non-NPO status is much more important than the carbohydrate drinks in the preoperative setting. So that's from that standpoint. We get 1 gram of acetaminophen in the holding area, as well as 20 milligrams of Celebrex, and 600 of gabapentin in the pre-op. So that is our pre-op medications. As you see, no opiates. The other thing I use as a side note here is we do have communication from the office to the preoperative area. And what I mean by that is that and I have a patient that I know is extremely anxious, or a very nervous or scared patient, I will just flag that patient by just shooting an email maybe to the PACU, or just talking to somebody and letting them know that this person may need a little extra care, rather than just have them there getting their benzodiazepines and to relax them. I rather flag those patients, give them a little bit of extra care, and still try to keep them on their same pathway. And then they'll have 2 heparin-locked IVs prior to surgery. Intraoperatively, again, this is really, we leave this up to our anesthesiologist. It's their choice on what they want to use, but we have some general guidelines or general treatments that some of them have shared with me. So we do fluid optimization with hemodynamic monitoring. I think we use a non-invasive monitor in the operating room. This allows a couple things. So if you talk to some of the anesthesia docs, or you talk to the hemodynamic people, they'll give you all the data on why it's so important to have these in there and to optimize the fluid. And I'm sure that's true. But what I think in our protocol that we found is by having the hemodynamic monitoring, whether it's accurate or not accurate in a laparoscopic patient or the patient in extreme positioning, what it did was it had everybody in the room, including the anesthesiologist or change of providers or the surgeon, think before we just barreled the fluids in. So we would have the fluids off, and then they would have some kind of protocol to follow during the case, that if there was changes and they needed fluids, they'd give them fluids. But if they didn't need fluids, they wouldn't just have it running at full speed. So we do use the non-invasive monitorings in our ORs. Anesthesia choice here, but again, some of the protocols would be propofol on induction, try to limit narcotics on induction. This is not just something that is unique to our hospital, but I know that there are some people that will give fentanyl all the time on induction. And speaking with other anesthesiologists and surgeons, I think this is one of those culture things that's very hard to give up on. We've gotten better at it, but we still get some narcotics at times on induction. We use ketamine drips, lidocaine infusions, short-acting gases. Again, I just go through all that because that's anesthesia. I'm just a simple surgeon. So nausea prophylaxis, there's a couple things that we do here. Some of it's evidence-based, some of it's not. We really like to stratify these patients into are they low, medium, or high risk. And when we do that, then more importantly than stratifying them, is that we like to do nausea prophylaxis, meaning that all of our patients will receive something. Usually they receive dexamethasone and ondansetron preoperatively with the goals of, again, preventing any nausea and vomiting. And you usually see that since we limit the amount of narcotics in the operating room and really don't have any after, once you get them through that initial surgery and waking up, that they really don't have the nausea. They're eating right away, they're up walking around, and they don't have narcotics. So if we just stop that nausea from happening during the surgery, we do find that it's much better off. Postoperatively, so we have put in our protocol to start with full liquid diets in the recovery room. We initially started off using clear liquid diets, but what would happen is a lot of time a clear liquid diet would be thought of as ice chips, and really that didn't work out well. So we moved it to a full liquid diet, so therefore they'll get a full tray. Even if it's not with them in their recovery room, that means once they arrive on the floor, they already have that diet order in, and so they have a full liquid diet and a supplement shake. And so just allow them immediately post-op to just keep their mouths happy. They can drink if they want. They can, just have it there. They don't have to drink it all down. We're not counting how much they drink or encourage. We just want them to have something there to keep their mouths happy after surgery. On post-operative day number 1, the morning after surgery, they will all get a GI soft diet. And I tell them all, I said, we're not going to go up and down or wait for anything. You get a regular diet on day 1. If you want to eat it, eat it. If you just want to pick on it, pick on it. If you don't want to eat anything and you don't feel like it, don't eat it. But again, we just like to have it there for them so they can stimulate themselves as they see fit. We stop the IVs after they're able to tolerate the first liquid diet. Usually that starts anywhere between, if they're an early case, post-operative day 0 at night or the next day. As far as ambulating goes, we like to ambulate at least 5 times a day. So on post-operative day number 1, we like to at least get them up in a chair and get them up moving around once, and then the next day we want them out 5 times. We've done a couple things with them as we've had different measured areas with steps on the floor in the hospital, and therefore they can count how many steps they go to, and that's how many feet they've walked. We've also given them pedometers that we had left over from our different cardiac walks and sort of give them some incentive. I think that when you have certain things like this, as well as we found another thing is that they meet people at their enhanced recovery class the week before, that they will make a little competition out of this. So when I come in the mornings, I hear every day now that the pedometers don't work. And I think that that's a good thing because they will then tell me how much they walked and how they want new pedometers. So I think it just plays a little bit of a game with them that encourages them to walk more, and I think it works. We always encourage the families or friends to get involved in the care. So we want the patients to take care, but we also want the families to get involved with their care. And it's great if they have somebody. If they don't have somebody, then we have different people that will help out on the floor. If we can get one of the PT to come see the patients, we also get some of our monitor techs to come over and help walk the patients. So we do whatever we can do if they don't have support to help them walk. So postoperatively, our MMA, what we use the liposomal bupivacaine. We do directed injections at the surgical sites, and we use these on all of our patients. We also use ketorolac 30 milligrams at the end of surgery. Sometimes we will decrease that dose depending on patient's age or renal function. And what we really like to do is we give the acetaminophen preoperatively, and then postoperatively or at the end of the case, we give the ketorolac. So then our goal is that postoperatively, we try to get it as close to alternating as we can, meaning get IV acetaminophen, IV ketorolac, one of them every 3 hours. Therefore, when you're on the floor and you don't have access to a breakthrough medication or a narcotic breakthrough drug, what you do is you give the IV Tylenol and the IV ibuprofen or IV ketorolac every 3 hours, and they have something with immediate onset. The other thing we use is gabapentin. We use 300 every 8 hours. So with those 3 or 4 things, meaning the liposomal bupivacaine, the ketorolac, the IV acetaminophen, and the gabapentin, that's our base postoperative pain management. The second line is if patients are having, some pain, it's controlled, but we think that they could get better, then we'll do other medications like ribaxin, or otherwise known as methocarbamol, 1.5 grams every 6 hours PRN. We can do that either intravenously or orally. And then the third line, if they're still having pain and discomfort, we'll go to tramadol, 50 milligram every 6 hours. So that's our pain regimen. Now, there's going to be patients that are going to not be able to tolerate, and they need to go to narcotics. It's not a failure. It's not anything. It's just trying to keep the patient, have a good outcome, have them out of pain. I personally believe that by treating it with an MMA, you're treating the pain itself and not just making them groggy, and that's why it's better than narcotics. But again, some people, they don't tolerate this and they do need narcotics. So, I want to say one last thing. What we have found is that when we discharge the patients home, whatever they were taking in the hospital is what we will discharge them home. So that means if somebody is just taking the above and they just are taking the ketorolac, acetaminophen, and gabapentin, then we will send them home with a script for gabapentin and discuss with them about taking acetaminophen and ibuprofen. If they went home and they're taking tramadol, then we send them home with a prescription for tramadol. If they're using narcotics, then we'll send them home with their narcotic script. So again, we found a significant decrease in the amount of scripts that we have had written. A little bit of our data, which has been submitted for publication now, but we looked at our last 303 colectomies, and with that 303 colectomies, we looked and found that 61% of our patients did not receive any opiates from the time they left the post-op recovery unit until they went home. 31% of our patients received no narcotics or no opiates from admission to discharge. So, for us, just implementing this and going in, we're really happy with those numbers so far. I think that since we even collected this data, which ended in April, I think we've improved even more because we just keep fine-tuning it with the education and really stressing to the patients and looking at different ways to handle their pain. So I think that that's all we have, and I will turn it over to Brian and hopefully give us some time to ask any questions you may have. And if we run out of time, please, you can find my email anywhere and send me any questions you may have.
Thank you, Dr. Nassif, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We've got a bunch of great questions coming in, and we'll go ahead and start here. So how have you changed your prescription pattern since implementing these pathways and protocols?
So as I described there, so we used to just, no matter what, you went home with either Percocet or Dilaudid oral, and that was it. And now we really have changed it not only to, I take that, so that's what we used to do. Then it changed that even when we were doing the opiate-free surgeries, we still would send people home with narcotics, I think more so out of just routine, but also because you said, hey, well, they're not in the hospital, they may have pain and they may need something. But we've changed that to, as I said at the end there, we now send the patients home with what they were on in the hospital. So if they did not take any opiates, or they only took opiates during the surgery itself, then they go home with instructions to take Tylenol, ibuprofen. If they were on gabapentin, if they were on Ultra. But again, what they were on in the hospital is what they will go home with. And if they weren't on anything, or if by the time they left they weren't on anything, then they don't go home with an opiate script.
Thank you for that further clarification. And we've got some more great questions coming in here. And this audience member wants to know what education has been given to hospitalists, surgeons, and PCPs to prepare them for using multimodals at discharge instead of opioids.
So what we've done is that as far as we go with the hospitalists, I have met with the hospitalists through our med staff. They have monthly meetings, and I've gone to all the different campuses and have explained and talked about what enhanced recovery was, what opioid-free was. The ones that we work with directly, usually I say, our hospitalists will admit our patients, and we sit down and I say, hey, these are our patients, this is what we go home to. As far as the other surgeons go, again, it's just a matter of educating. Surgeon part is very easy, because once one surgeon sees somebody doing something that they're not doing, they want to copy it. And that's just how it is all along. We don't want anybody to do anything different or better than us. So they will follow along. But it has been a lot of education. I've done personal, just go to the med staff meetings and the hospitalist meetings for internal medicine, through family practice talks, and I just will go and try to explain what we're doing and what it means. And I think part of this means you have to have invested interest in your patient, meaning that you need to communicate with the hospitalist that's taking care of your patient. When they're going home, you sort of have to have communication. And I think we lose that sometimes in hospitals, which is wrong. We need to communicate directly with these folks and allow them, on each case per case, patient per patient, just to touch base and let them know what's going on. So it's a lot of communicating, a lot of, like I said, gone to a lot of talks and just explain to what we want and what we're doing.
Great. Thank you. And our next question here. So treating opioid-exposed patients may require further teaching and planning. Any ideas on how to engage their acceptance?
So, what we've done is the patients, in my practice, we have a good bit of young patients who have more chronic diseases like the Crohn's or ulcerative colitis patients. And a lot of these patients are on chronic narcotics. So, we have the same talk with them beforehand as well as throughout the education process. And I tell them this, if they've been on opiates for 2 years, I'm not going to bring them in the hospital next week and stop them. So what I do is I tell them, you're going to be on what your medication was at home. The old mentality used to be whatever you were on at home, you get that and then more to take care of your pain. But we put them through the same way, saying, hey, you were on X amount of narcotic daily, you're going to have that. But you're going to go into this, this multimodal pathway that we have, and we use it for everybody. And I just explained to them, you're going to get what you get. But this is going to help you with your pain in a different way. And, that's the hardest patient population. However, when you have somebody that was truly in pain and you operate on them and you put them through this pathway, they realize it's better and they go along with it. When you have somebody who's on the narcotics and at this point, they want to get it, they're going to get it. So, there's some way you can't avoid it, but the other way is it's, again, give them what they have, educate them on what we plan on doing with them, meaning the opiates reduced MMA, but that they're still going to have their medication. I definitely wouldn't just stop whatever they're on when they come in.
Great. That's important to understand. And sort of building on patient interactions a little more, this audience member wants to know, what app do you use for the patient education?
The app we use is called Twistle. So it's an app that we've used now over the last couple years, I think about the last year and a half. And from our standpoint, what's really nice about it is it gives the patient education, access to us. We have access to them. It's cut down significantly for us on the phone calls after, because these patients through the app can send pictures, they can ask questions without having to sit on the phone and get back to them. So it's a nice tool to have to sort of bring this era of, I want to say, almost concierge type medicine together.
Thank you for that. And this audience member wants to know, what kind of drink do you give to your diabetic patients?
So on the diabetic patient, we just brought this up, we were talking with our fellows. So we will have them get clear liquids. Again, when I have them have the liquids, and when we looked at this data over and over again, more important from my standpoint is I want the patients to not be MPO after midnight. So I really encourage them to have the clear liquid fluids and keep hemodynamically normal, if you want to think of it that way. As far as the diabetic patients, we do have a list of, what we like them is taking the Propel drinks or the sugar-free drinks. So that's what we add to them. Again, specifically, I personally emphasize to them just the need to drink, whether, I don't care if that's water, I don't care what they're drinking. I just want them to not be dehydrated and not be hypovolemic at the time of surgery. But again, on our list brochures, they have some sugar-free drinks, and we suggest things like Propel. I think it's Propel or H2, whatever the one's sugar-free.
Thank you. And our next question here is, Dr. Nassif, did you get pushback from staff on encouraging family to help with walking for fear of falls, or do you have an education for family on this?
No, we didn't. Part of the reason was we wanted to get everybody up and walk around. And when we looked at this as a unit when we were setting this up, it's very difficult to say, hey, I want the people up walking around 5 times a day. And to me, it just made sense, just get them up and walk. But we had physical therapy, and they would be able to do it maybe once a day. You had the nursing staff, which, they're so busy and so, outnumbered nowadays that it's very hard for them. But even if you got them to help walk one time. So then we looked at other resources we could use, and we found that some of the monitor techs would be able to walk the patient. But still, we didn't know how else to get the patients up and walking around. So we always encourage the family to help. Now, one of the things you got to remember is now that the patients are not on opiates, now that the patients are not groggy, they're out of bed on day 0, and on day 1, they're up, eating, walking around, they're wide awake, they're in complete sound mind, they're not wobbly on their feet. So when you have all that, it's a much different person to walk than, when they were getting a PCA with, a breakthrough narcotics, and, it took 3 people to help you out of bed. So no, I don't get nervous about that. We encourage the family. We have nursing. The nurses and the PT will usually get them out on the first time to make sure they're steady. But again, we encourage them to walk any way possible. And again, it's a very different patient that is strong and, has their sea legs on them. So from that standpoint, no, we don't worry.
Thank you. And our next question here. So how long has this protocol been in place at your institution?
So we started this over 2 years ago. And when we started it, we have a different type of hospital in that it's very large, but I like to say it's a large community-based open medical staff. So it's very hard because there's not a big department or a big chairman. There's many different units. So when we started doing this, our goal was, hey, we're just going to pilot the program, see what happens, get it moving. That turned into a good bit of time. So we've been doing this consistently for over 2 years, but even before that, it took us a good year to get it really going. And what we found was that there were tons of mistakes. We would go and we'd say, okay, I read this is how you do it, let's implement this. And we would then have a patient follow through the whole process, and we'd find a million different areas where we could improve on. So that process to really get through 20 good patients, it took us, a little under a year, probably about 8 to 10 months to get the process down to implement this. We learned so many things that along the way that are sound easy. And again, one of those things being that I spent a good bit of time making a brochure, and then I brought it to marketing, and they said, oh, you can't handle that out, and you have to go back to step one again. So once you have the process down, then it's very easy to implement if you have the stakeholders. If you have a surgeon, the anesthesiologist, and administration behind you, then it'll work. I suggest that you start off with a surgeon or a group of surgeons and one surgical floor or one anesthesia. I think that if you go and try to implement everything all at once, you have a lot of different areas that you can screw up in. So I think you just get a champion, somebody in each one of those areas, and just see how the process will work at your institution. Once you see the process is good, then you implement it and roll it out across different service lines.
Thank you. And we've got a bunch of great questions today. And so we're going to go with this for the next one. So if the patient already takes gabapentin 300 milligrams every 8 hours, do you change the post-op routine?
So, with that one, I have spoken to some pain docs as well as anesthesia on this. And so when patients are on the gabapentin, it's my understanding, talking with them, that if the patients do not have any reaction, meaning that they don't have any side effects or lethargy from taking Neurontin, you can dose escalate that much higher in those patients. So I look at it, I say, if you have a reaction to gabapentin with 1 milligram, then you have to stop it. But if you're fine with 1 milligram, you can go up to as much as you need. So yes, so we will increase their gabapentin along as they tolerate it. But again, it's definitely, if they tolerate it at 300 3 times a day, you can increase it. If they don't tolerate it on their first exposure to it, then you can't. So yes, we will go up with that. It's usually not the first thing that we do. We don't go up on Neurontin. We usually will add then something else. But that's probably a good idea, even as I talk about just increasing the Neurontin rather than go to the next step.
Thanks for clarifying that. And so what do you recommend for patients with documented intolerance of pentanoids and leterolac?
So what was that again?
What do you recommend for patients with documented intolerance of pentanoids?
Of gabapentinoids? I would just, we just cut it out. Yeah. So if somebody has, that's our baseline. So if they have an intolerance to it, then we don't use it. If they get, as I said, lethargy or have a reaction on that first, we just stop it. And that goes true for anything else. I know a lot of people will ask about the Toradol. So Toradol will dose relate it to age, and I'll dose relate it to renal insufficiency. If somebody's creatinine bumps up, then we just stop it. I don't look to add anything new if we don't have to. We just see where it goes. So we'll just eliminate and still go down the protocol.
Thank you. And so do you use these same programs for outpatient surgeries as well?
We do not use it in our outpatient. We have, one of the things are there's so many different outpatients in our system. We tend to do certain components in the outpatient. For instance, we don't have an education class for the outpatients. However, we do try to use the IV Tylenol as well as the Toradol post-op, as soon as they finish the cases. We also have done some of the quality measures with, calling the patient, see how they're doing, instructing them that way. We do, like I said, we do not have any formal education program for the outpatients, but we do the rest of them as far as the MMA. We try and do that. I have decreased or changed my prescribing patterns for the post-operative patients now that we use the liposomal bupivacaine. So I used to just send everybody home with either oxycodone or hydrocodone. But most of the patients now, if I am going to send them home with a narcotic script, or I eliminate that and we'll send them home with a tramadol script. So that's how I've changed in the outpatient setting.
Thank you. And it looks like we have time for maybe a couple more questions.
Okay.
So how did you overcome the shortened NPO status for patients?
The shortened MPO status. So before I ever get in any battle or argument, I always got to do my homework. And when we look, the actual guidelines by anesthesia, or the ASA guidelines, were MPO of clear liquids, not full liquids, clear liquids, 2 hours prior to surgery. So again, I went and looked at that, and then we also looked at a couple different protocols and say, hey, this is done, it's safe, and this is what the recommendations are. So I just did that, and we brought it to the team, and Chad Pritz, who is one of our anesthesiologists, was on the team with us, and he was totally for it and agreed, and just disseminated it from there.
Great. And so how have these new protocols impacted patient satisfaction scores?
So they have improved our patient satisfaction scores. And for us, it's easier to gain because we do have a hospitalist, that the HCAP scores in the hospital have improved. But I have personally, on my scores, noticed that our in-office Press-Ganey scores have improved. More importantly is that the feedback that we get from the patients post-operatively. So, you get a lot of these, the Press-Ganey scores in the office, and you don't know pre-op, post-op, but we are finding that our post-operative patients are coming in happier. They really feel empowered by the fact that you are doing the education. They feel that they had a decent hospital stay without any, pain. And so you really you get a different feel post-operatively on the patients that did well through the enhanced recovery and through the MMA or opioid-free than on the patients who, didn't do the same way, or the patients we were seeing 2 and 3 years ago. So as far as measurement-wise, I'd love to say that my Press-Ganeys and HCAPs were always perfect, and this didn't make a difference, but I think it did make somewhat of a difference there. But I think more importantly, the patients we see post-operatively is a big difference.
Great. Thank you. And this will be the last question we have time for today. So what patients have required narcotics, and how long have they required the narcotics?
So the patients that have required narcotics usually have been the patients that post-operatively had some kind of deviation. And what I mean by that is if they had a infection post-operatively, or a prolonged stay through a reoperation, or patients who may have had a reoperation and had an ICU. So those are the patients that strayed away from the pathway. So when it's, when things were normal and everything was perfect, even, patients who may have had a little bit of narcotics during the hospitalization, but not a ton, and were eating, they did okay and weren't sent home. It's the patients that deviated from the clinical pathway, whether that was reoperation, infection, or some kind of side effect after surgery.
Thank you. That's helpful to understand. And it looks like that's all the time we have for today. I want to thank Dr. Nassif for his excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.